This conference will now be recorded.
I'm glad you said that because I wouldn't have remembered to do that little button. Okay, let's get started. What I hope to do next time is add a simple sort of a tabletop for COVID-19, because I'm sure that if you get the numbers that the rest of the country gets, there's going to be an opportunity to write that up as an actual exercise. And so I'm going to try and find some good information to help you do that and make that easy for everybody. First of all, though, I want to just thank you all. I am impressed beyond belief, and always have been, with our medical staff in our different clinics about what you're doing out there, and adjusting daily to changes and whatnot. So just a thank you for that. Really, really appreciate what you do. So let's talk about for the first part about COVID-19, since it clearly is emergency preparedness. A little bit about social distancing. I think this slide says it all in terms of what one person can do if they don't social distance. In 30 days, one person can potentially infect 406 people. That's a lot of people. But if one person really works at social distancing, even if they're infected, we're talking 2.5 people. So it does work, and it seems to be working throughout the land. In the beginning, it didn't look like people were really going to pay attention, particularly the younger folks, because they're invincible, but they're getting it now, and a good thing they are. So the last set of slides said 2 weeks to slow. Now we're to flatten the curve. Now we're 30 days to slow the spread, and it didn't copy well, so I put the words over here. It's really very simple. If you feel sick, stay home. If your children are sick, keep them home. They're not going anywhere anyway right now. If someone in your household has tested positive, keep the entire household at home. If you're an older person, stay home and away from other people. And if you're a person with serious underlying health conditions, that can and will put you at increased risk, stay home and away from other people. And of course, this came from the CDC.GOV, which is a changing website almost every day. On surfaces, this virus, in aerosols, less than 3 hours, plastic, 2 to 3 days, stainless steel, 2 to 3 days, copper, 4 hours, and cardboard, 24 hours. So we have just some different times that this thing lasts in the surfaces, and it's changing all the time. They're learning every day. You hear these briefings every day. Yesterday, I just added this morning. Yesterday, I heard a wonderful woman. Her name is McGoldrick. She's a infection prevention control nurse. Big degrees. And one thing she said shocked me, and I had forgotten about this. When Ebola happened in Texas, 2 nurses did not remove their PPE properly and infected themselves. Now, they lived, but still, it's not a good plan. And we want to make sure we understand. Now, you're not probably doing this degree of PPE, but you are doing some. And so I really think it's important. I didn't put the slide in on how to put it on. I think everybody knows how to put it on. But we don't train regularly on how to remove, or they call it doffing, the PPE. So there's many methods. This one happens to come from the CDC, and I have a few things I'm going to offer to you that are different than this, but we'll talk about it. So number one, so let's pretend you're gowned, gloved, and masked and in an exam room, and because you have a patient who's suspect. We're going to talk a little later about how we don't want that to happen, but it could happen, certainly. So remove the gloves first. That's the rule. Ensure the glove removal does not cause additional contamination. So there's a way to remove gloves. I couldn't do pictures of videos here, so I suggest you go on YouTube or CDC and find that how to properly remove gloves. Obviously, you're not touching your skin with any part of the outside gloves. Then you remove the gown, untie all the ties, snaps, or buttons. Some of them just pull and you rip it, and you don't want to do that too forceful, as it says, because you'll be showering things around. And you roll it down your chest, literally pull the arms out, roll it down, and dispose in a trash receptacle. Now, we're still in the exam room here. Now they're saying that the healthcare personnel may enter the exam room. I called an infection control specialist today that I happen to know in Louisiana to get the question here. My question was, wait a minute, now we're going to touch the doorknob? I don't like that idea. And he suggested very, very clearly that by that door, if you would have a box of wipes or a container of wipes that you use for tables and whatnot that'll kill this thing, grab one of those, have them sticking up, grab it, and take that to the door, because now you have no gloves on. All you have left on is your mask, and you do not take that off until you wash your hands for at least 20 seconds. Then you remove your face shield or goggles carefully, but grabbing the strap and pulling it forward, never touching the front of it, and discard it. And so it seems like not necessary, but guess what? We have a lot of healthcare people who are becoming ill over this thing. So we really want to make sure that we train our folks on how to remove that gear if you have to gear up in a clinic setting. And I know you are. I hear it every day. And then, of course, again, perform hand hygiene. And that's a given. Hand washing, and more hand washing. This is a new one. I just saw this on CDC yesterday on stopping the spread of germs. Some very simple things there to the right. Avoiding close contact. Obviously, you know that. Covering your cough or sneeze. Tissue in the trash. Never touch your eyes. We're going to talk about that in a minute. Or your face, actually. Clean and disinfect frequently. Touch surfaces constantly. Keyboards, phones, all those things. Your own car keys. I mean, all kinds of things depending on what you're in contact with. Staying home if you're sick, except to get medical care. Now, you guys can't do that. I do that. We are sequestered here in our home once a week for groceries is it. And then wash your hands for 20 seconds with soap and water. All right. I also heard yesterday that alcohol-based hand gels do not work as well if your hands are wet. So you're going to do that on dry hands. And they do work, but on dry hands. So I got this off your website yesterday, the Oregon Office of Emergency Management. As of April 7th, you have, looks like a lot of masks, respirators, gloves, and face shields. I want to hear from you at the end. Do you have enough? Because this is a state website. I hear from clinics that it doesn't always filter down that far. And then your peak. Your peak is, according to the CDC, May 5th. That's a ways off yet. So you need to now be preparing for this to come. You're still relatively low in cases, and of course you have had 25 deaths. Proportionately speaking, that's a pretty good number. And there's the counties where it's at. And this is yesterday's number, so I hope it isn't more today, but it could be. But remember, they're suggesting that your peak is not coming till May 5th. And this is also from your site, and I thought this was good. Do your part. The Oregon COVID-19 Daily Update, which is on the website at the emergency management, social distancing, good hygiene, responsible shopping, preparing your home, protecting your mental health, which is really important for people that are sequestered by themselves and lonely, coping with stress and crisis lines, and then 2 weeks ready. I thought was interesting that you should always be prepared. They're recommending always have 2 weeks of supplies, food, water, whatever in your home at all times, not just now. So this is a door sign that we recommend that you put up on your door. Stop for safety. I will tell you that patients are not noticing it for whatever reason. They're used to coming to your clinic and they don't actually see it and they just waltz right in and they're symptomatic. I have 2 clinics that I know about who are now locking the door and it says, stop, go back to your car and call us and we'll decide who comes in or who we go out to see in the parking lot. I just cleared it with some people yesterday. When you see a patient in the parking lot of your clinic or at the curb of your clinic because they're symptomatic, that is a normal RHC visit. Don't even hesitate to put that through billing as a rural health clinic visit. This is a national emergency. We have to keep patients safe. We don't want those patients to come in the clinic that have the cough, the fever, if in any way possible to keep them out. You go to them, gown up, mask up, glove up, go out to them with your thermometer, see them at the car, and deal with it as you wish, whether you're sending them for testing or whatever. We're going to talk more about that. But put your phone number, put this on your door and your clinic phone number. You might also add, have you traveled outside of the country? Have you traveled to New York, for crying out loud? Have you traveled to Washington State? So people to try and jog their memory that they might be positive. So go to the car, give them a mask, and triage the patient. Ask these screening questions. I got ahead of myself there. Have you traveled? Where have you traveled? Have you been in contact with someone who has the virus? That's a key question. And then check for fever, sore throat, shortness of breath. If suspicious, you have 3 choices right now. You're in the parking lot of your clinic. Send them home. If minimal symptoms, to self-quarantine. And with instructions, of course, if things get worse, what to do. Send them for testing or send them to a hospital if your providers have decided that this patient needs further care immediately. And then, of course, you're going to inform prevention and control services in your state. And I know they're in your binder, so that's in your emergency preparedness binder, who to call and what to tell them. And any of healthcare facility staff as appropriate if you have to call the hospital, etc. Limit the number of patients in your waiting room, if you have any at all, and take half the chairs out, literally separate them, so that if anybody is sitting there, they're not sitting. You've got the social distancing going even in your own waiting room. And try not to touch your face. The mucous membranes on your face are easy entryways for this virus. It sounds simple, but there was a study, yes, someone paid for a study, that people touch their face an average of 92 times a day. That's a lot of touching going on. And when we're stressed, we tend to touch it more. You know, you rub your face, you rub your eyes, whatever. Try not to do that. Once you say that, now you're going to be more conscious of it. And so if nothing else, that'll help you to remember that. You don't really know what you are touching these days. So for suspected positive patients, use one room only and have a sign on that door. If the patient is able, they should come in alone, no other person. And of course, alerting public health authorities. Keeping a log of everyone who enters that room, the staff included, so if we know we got a problem, we know who was in there, who was exposed. Keep the number to a minimum, only essential staff and PPE for them. And if you're using non-disposable linen right now, if it's at all possible, to switch to paper because we're going to throw it away and we're not having to deal with decontaminating real linen at this point. Train your staff, take daily staff temperatures. That's your staff in the morning. Take their temperature every morning. Let's be sure there are many people that are asymptomatic, but they might have a low-grade fever. And the first sign of that, you're going to send them home. Ensure that clinical staff know the right ways to put on, use, or take off PPE. That was in my slides before. I never realized what an important statement that was till yesterday. Recognize the symptoms of COVID-19, fever, cough, shortness of breath. Implement procedures to quickly triage and separate. Emphasize hand hygiene and cough etiquette for everyone, and ask staff to stay home if they're sick, and then send staff home if they develop symptoms at work. This is a lot of repetition, but I find a different way to say the same thing, we might make some headway. Now, if you send someone home for isolation because they're potentially positive or they have a fever or cough, but they're not symptomatic enough to go to the hospital. So people with COVID-19 who have stayed home can stop isolation under the following conditions. These are positive cases. If you will not have a test to determine if you're still contagious, and getting a second test is seriously a challenge, especially in rural. You can leave home after these three things have happened. Not an or here, these are ands. You've had no fever for at least 72 hours. That's 3 full days without the use of Tylenol or anything else to reduce the fever. And other symptoms have improved, such as your cough or shortness of breath. And 7 days have passed, at least 7, since your symptoms first appeared. So those all must be true before you can go out in public again. If you will be tested to determine, then you can leave home after these 3 things have happened. You no longer have a fever without medications, and other symptoms have improved, and you've got 2 negative tests in a row, which, again, that's tough to find that happening, and those are CDC guidelines. So let's move. Actually, Randy, let me ask if there's any questions on that before we move into the emergency preparedness guidelines.
Kate, there are no questions in the chat box.
Okay. All right. Anybody want to unmute and ask one? Good. Okay. So the goals of this from here on in then is to be able to state the requirements at 491.12, which is where EP is, be able to identify resources to complete a customized EP plan, and be able to state the rationale for that after action report. And of course, an after action report can be after a exercise, a tabletop, or an event. And certainly we are in an event. We most certainly are. And I would be surprised if any of you had put pandemic down as one of your risks. You may have with flu. You very well may have. Maybe next year we can decrease the deaths in the flu season by just simply not even shaking hands. So your emergency preparedness plan requires planning for things we hope will never happen. And boy, isn't that statement true right now. We never thought we'd see this, and here we are. I've certainly never seen this in my lifetime. On-site events and emergencies which may put staff and patients at risk. Off-site events and emergencies which may impact the delivery of service to your patients. And contingency planning for interruption of healthcare services. So this all started in 2005, and that is the inside of a hospital in Louisiana. with Hurricane Katrina. In 2005, only 25% of office-based providers were using electronic medical records. And I would bet on this call there might be one or two people who aren't using EMRs, but for the most part we are. But at that time, entire lifetimes of healthcare documentation was lost forever. And even chronically ill patients, critically ill patients, no records. And EMR, of course, is now the standard. This Dorothy Jones, and I got this out of a newspaper article, the information supervisor at Medical Center of Louisiana, she thought removing the bottom rows of records in her hospital would be good with this storm coming. Well, guess what? 400,000 medical records in her hospital were reduced to pulp. And that's the kind of thing we're not going to have happen with EMR. This was Hurricane Sandy in 2012. And while that's not a medical picture, it demonstrates the severity of that storm and not so long ago. But guess what? They had no loss of medical records because of EMR being the standard of care from Hurricane Katrina to Hurricane Sandy. With Hurricane Sandy, while water was impossible to hold back, the availability of health information after the storm was remarkably stable because of the cloud and where we keep our medical records. Among the users of EHR in greater New York City area, there was only one report, I said none, I apologize, of records being lost in a small clinic that was still in the process of converting. I'd forgotten about them. However, there was widespread reports of paper records being lost. In New Jersey, fewer hospitals in the direct impact zone, the State Regional Extension Center program planned in advance by contacting providers prior to the storm's landfall with instructions on how to back up their data. If you remember, and it's right in the regulations, one of the regulations requires that the backup not be on site. So we used to have these towers in the back of the clinic where the EMR was in the disk back there. That's no longer acceptable with the 491.12. In 2013, in Moore, Oklahoma, this was a F5 tornado that took out that very clinic right there, and it took them 4 years to rebuild, and they lost a lot, and were displaced for a long time. And that is an area that is prone to those. 2015, this was an active shooter situation, 14 people killed, 22 injured. We now have guidelines for that: run, hide, fight when immediate threat is noted. And that is always a good exercise to do as a tabletop, or to get your local police involved with that, and they will do that for you in most areas, because this is a reality. We are seeing this in clinic. I will say, I did a tabletop with the state of Idaho on the agitated patient. And that turned out to be one of the best experiences for me, because the entire audience, I was actually live there, not webinar, everybody's had that. Everybody in the room, and I would bet that you do too, have had an agitated patient in the waiting room that we have to talk off a cliff, if you will. 2017 was Hurricane Harvey. Particularly hit was Texas. This nursing home in Florida, this is the actual nursing home here. Their problem was communication. I'll never know how the pictures got out. That place is closed. There's a million lawsuits. People died. They couldn't get the word out that they needed help, and that the patients were stranded in there with flooding and people in wheelchairs right up to their waist in water. 2017 in the UK was a hacking, and this caused major problems. Ambulances stopped. Emergency rooms closed, surgeries were all canceled. They couldn't do anything because their healthcare system was held for ransomware. We just had this happen to a clinic, one of our clinics in the United States, during this time. The crooks know how to take advantage of bad situations, and we all need to be mindful of that and make sure that we've checked with our IT people that we are secure, that our situation is good. That clinic couldn't see a patient because they had everything. Well, they did see patients, but they had no records. They couldn't get into their own medical records. I don't even want to tell you what state it is. In 2017, of course, we had the big campfire in California, and that was huge lessons learned. When to evacuate, getting ambulances. A lot of lessons from that one. And getting ambulances was a big problem because they were all called by the state to come and do different work, and this own hospital could not evacuate their own patients. It was a nightmare. Okay, so let's talk about the regulations. Today, we're going to talk about risk assessment and policies and procedures. Next time, we'll do that tabletop and communication plan. We'll talk about communication today. Next time is training and testing, and that's the big load of this thing. So the risk assessment. Your EP plan must be based on and include a documented facility-based and community-based risk assessment using an all-hazards approach, including strategies for addressing emergency events identified by your risk assessment. So if you choose 5, 7 things in your risk assessment, then you will have the exact number of strategies for addressing those events. Addresses the patient population, including the type of services that the clinic has the ability to provide in an emergency, and continuity of operations, including delegation of authority and succession plans. Who would have thought that, I think it was Friday night, as I said, I'm losing track of days, I got a call from a clinic manager in California in the desert. The county knew that he had 7 empty exam rooms. This is how granular this gets. 7 empty rooms, and they were going to move recovering COVID-19 patients from the hospital 40 miles away into those rooms. Listen to what I'm saying here. They were going to bring hospital beds, IV fluids, and he was supposed to staff this. He didn't even have staff that really did IV therapy, knew how to, they might have when they were back in the hospital, if they were. But, we talked this out, and I said, listen, they're going to require that of you, and it was you couldn't say no kind of thing. You need to have them give you some guidance here, or maybe a staff person. They were going to have 2 shifts, 7A to 7P, in his clinic in this week. We're talking now. These are extraordinary times, but no one could plan for that. I was shocked at that one. And that's what I said to him. Do you have beds? I mean, you have exam tables? He said, no, they're empty rooms. They're going to bring beds. Fascinating scenario. Matter of fact, I need to follow up with him and see how that's going. So we want to include a process for cooperation and collaboration for the local, tribal, regional, state, and federal emergency preparedness official efforts to maintain that integrated response during a disaster or emergency situation. You just don't know what you're going to be called on to do. Now, it used to be that you had to include documentation of your efforts, and I left that here because while it is now way back in November, you no longer have to do that. You have to give their names and their phone numbers in your policy. You don't have to write a paper that you called them and they didn't answer and they didn't communicate with you or whatever. No longer required. That went away with the burden relief. Okay, so the all hazards risk assessment. Kaiser, and I know you've all done this, but if we're looking to improve this at this point, Kaiser Permanente has a great tool, and you can find it on the internet. If you just Google some of these words, you'll get it with instruction sheet and everything. And it's really appropriate for clinics. So what events are most likely to impact the services your organizations deliver for patients? Always weather events. We all need to have, as one of our events, weather. In Oregon, maybe you have, I'm trying to think of what you have. I should have looked that up. What weather do you have? That's the big event. I hope not a tsunami. That's what came to mind, but we don't have that, thank goodness. Power or water interruptions. Provider or staff illness. What if your main provider goes down? How are you going to take care of your patients if you're a one-man shop? Or even if you're a 2-man and you can only work so much. Technological communication failures, fire, of course, wildfires, and floods. And there are all possibilities. So this is an icy weather plan activation. So this is just some ways one person put this together. Number one, and the 3/4 of an inch predicted schools are closing. Inclement weather closes the schools, and then the clinic closes. The staff is called, patients are texted, the office closed messaging is on the door, is on your machine, perhaps on social media, the snow code on TV or radio if you have such a thing for clinics. Change in operations, exposed pipes covered, generator check, supplies for ice treatment, planning for after event, and then the close sign, and then of course the next thing is the after action report. So that's just a process that could happen to work through in an icy weather, but you could put any words in there that could happen. A chemical leak, a mass accident, a shooting, COVID-19, certainly. This is just some ideas if you haven't done your risk assessment. Man-made events, shooters, cyber attacks, bioterrorism, power outage, chemical events, mass casualties, natural disasters, tornadoes, hurricanes, severe storms, earthquakes, floods, and then public health emergencies such as where we are, flu, Zika virus outbreak, biological hazards, and of course I added COVID-19. The funny thing was, Loss of provider is a real issue in rural health clinics because we're stretched so thin as it is. For the life of me, I couldn't decide which category to put loss of provider. Yes, it's man-made, but it could also be a public health problem. It's certainly not a natural disaster, so I kind of left it there at the bottom. You can help me decide where to put that for the next presentation. The interpretive guidelines for risk assessment say the EP program must describe the RHC's comprehensive approach to meeting the health, safety, and security needs of their staff and patient population during an emergency or disaster situation. The plan will address how the clinic would coordinate with other healthcare facilities, as well as the whole community during an emergency or disaster, whether natural or man-made. And the Emergency Preparedness Program must comply, obviously, with all laws, federal, state, local laws. That goes without saying. So what policies do we need for this? The policies and procedures must be reviewed and updated biennially. Used to be every year, now it's every 2 years. At a minimum, the policies and procedures must address the following: safe evacuation from the clinic, which includes appropriate placement of exit signs, staff responsibilities, and the needs of the patients. Now, you should have this for your fire policy in the clinic. You should have exit signs that I can find in the winter in the dark. It's 5 o'clock, it's already dark, and there's smoke filling up. Can I find that exit sign? We require floor plans in the clinic where I can't see one of those exit signs. So if I am on an interior hallway, I need to know which way to turn if I can't see one of those lighted exit signs. We want to go toward the exit, obviously. And what are the staff responsibilities? Who gets to make sure the rooms are cleared? Who accounts at the tree on the corner where we've agreed to meet, that kind of thing. Number 2, a means to shelter in place for patients, staff, and volunteers who remain in the facility. Shelter in place for clinics does not mean what it means in the regulations for critical access hospitals, where they have to have X number days of food, clothing, blankets, water, those kind of things. Shelter in place means there is a tornado coming or there's a chemical leak and we're going to hunker down until all clear is given to leave. And that's the difference. It's a short-term shelter in place because we don't have patients sleeping at the clinic and under normal situations. Number 3, a system of medical documentation that preserves patient information, protects confidentiality of patient information, and secures and maintains the availability of records. So this is what I was referring to before, where even though we were on EMR initially in the early years, the backup was in the back room of the clinic, in the usually where the mops were back there, that big black tower, which showed we'd even take a disk out of there to take home or lock in a safe or something. So that's very important that does not happen now. Your EMR needs to be backed up in the cloud somewhere, and the law says geographically different than the clinic. So yes, it can be across the street in the hospital, or it could be in Kansas City, but it isn't going to be in the clinic itself. Number 4 is the use of volunteers. Volunteers in an emergency. Now, that is in the regulation, the use of volunteers. For our purposes, and you would need to be certain that the state of Oregon will accept this. If you're surveyed by us, we accept a page in your binder that says ABC Clinic has decided not to utilize volunteers. Because if you use volunteers, you will name them, you will prove that they've been HIPAA trained and that they know their duties in an emergency situation. When this came out, I called CMS a couple years ago now and said, this is hospital regulation. We don't have volunteers in clinics. I have never seen one to this day. And they said, yeah, we know that's a hospital regulation. I said, okay, I get it. So in a hospital, you have pink ladies and candy stripers and the rest of it, and they're there. They're there every Tuesday, Thursday, or whatever it is, and they do have responsibilities, and you do have to train them. But we know in an emergency in a clinic, the volunteers that would help you are anybody that's in the clinic or family members of clinic staff who are able-bodied and able to help you. And that's who the volunteers are going to be. And who knows who those are going to be. So we accept that paragraph in your binder that says, we're good, we're not having volunteers. Will you use them? Of course you will, in the right situation. So policies and procedures further, RHC will comply with all federal state laws. We talked about that. The P plan will be reviewed at least biennially and updated with any changes arising from findings with the after action report. So there would be nobody's plan this year in early 2020 that isn't reviewed and updated after this event. I would be shocked if it wasn't. So we're going to find glitches or holes in our system. If it's perfect, that's awesome, but it would be likely that most plans would need to be at least updated in certain parts of it through this emergency. Addressing your patient population. So, for example, if you have a second floor clinic in a medical office building, how do you get those patients out? Do you have a way to get them out if the elevator's down? That kind of thing. And then services offered during emergency events. What services can the RHC provide during this pandemic, let's just say? So we have a number of clinics, typically in larger systems, provider-based, where there are more than one clinic, and they close one or two and use that staff to go to the hospital. Because let's face it, office visits are pretty well down across the country for patients that aren't COVID positive. They don't want to come out to you, which is why the very necessity of telehealth is rearing its head. We've needed it for a long time, and this may get it done for us. But that is a possibility. You can temporarily close your clinic, put the information out, you notify the state, tell them where you're going to be seeing those patients from that clinic, and then use that staff otherwise. Or perhaps they're not working at all. That, of course, is up to you as needed. The communication plan must, of course, comply with state laws, and you must update it at least biennially. Now, we find in rural health clinics that sometimes the staff changes a little more frequently than biennially, so that list of contacts from the clinic staff may need to be updated more frequently. It includes the required contact information. It also includes alternative means of communicating: text, email, phone, social media platforms. How are you going to communicate with your staff and patients if the landlines are down? And most clinics will choose the cell phones as an option. Of course, that's a good one. Provide information about patients. So how do you track patients in your clinic for transfers? The American Red Cross Patient Reunification Program. What are ways that you can get some help when you need it? And determine clinic needs and the clinic's ability to provide assistance to the community. How can you assist in your community if there's an issue or an event right in your town? So I already discussed this, how our clinics required to have volunteers, and you do have the flexibility to say no to include volunteers. If you do have them, they must be trained on your policies and on your EP plan and HIPAA trained for sure. The communication plan must include the staff, which includes the providers, entities providing services under arrangement, other RHCs or FQHCs, volunteers, and this is where you would put an NA, and federal, state, tribal, regional, local EP staff. Now, don't forget to include the other RHCs. For some reason, we find this missing a lot of times. Find the nearest one within 40, 50 miles and put their name and phone number. That's all you have to do. 40, 50 miles is actually a very long way in an emergency like this. They're not likely to be much help to you. But the law calls it out, so maybe it's an FQHC that's closer, and you can put that in. Why that's there, only the federal government would know, but it is there in the law. And rethink the phone tree. Compile advanced emergency phone trees, which not only request staff member phone numbers, but also perhaps mobile numbers, email addresses for mass communication, emergency family contact information if someone's down in your clinic and we need to get the family, alternate addresses in case of temporary location. Where, like that tornado that hit that clinic in Oklahoma, where are we going to see patients if our clinic is unavailable tomorrow morning? It happened in Louisiana with a big flooding last year where clinics were down and they had to relocate temporarily to find a place to see their patients. And so that should be in your plan, that we have at least an idea where we might set up shop if our clinic building is no longer usable. You must have a means of providing information about the general condition of location of patients in your facility. If something happens in your facility, how do we get the word out? We need help. We've got 3 patients down. We've got whatever. We need assistance immediately. And you're going to work with your local police departments on a lot of these things. A means of providing information about your needs and its ability to provide assistance. Again, what can you do for the community? So FEMA, of course, is a great website. This emergency, we're on CDC.GOV just about every day. But for other things, depending on what it is, FEMA, of course, is doing a lot in the communities right now. Okay, so the next time we're going to talk about training and testing. What we train for, we succeed in. That's called muscle memory, and that's why training and testing is so important. And I just want to give you a quick idea here on what we see. Having the EP plan, but not training the staff. We'll go over this again next time. Omitting the required contact information. Lacking the all hazards vulnerability assessment. For those of you that opt into your hospital's emergency preparedness plan, you still must have a hazards vulnerability assessment, even though you're in their plan. Because even if your clinic is in the building of the hospital, yes, your weather events are going to be the same, but you could have an event in your clinic, in the basement of the hospital, loss of provider, shooter, any number of things. So it's still required. And then when provider-based clinics do opt into the integrated healthcare system, they don't meet that higher level of documentation, and it is a higher level, and we'll go through that next time for sure. Outpatient providers are not required to have policies and procedures for the provision of subsistence needs. We get that question a lot. That is not required. That's not what shelter in place means. RHCs must still have a policy procedure detailing how your refrigerated medications will be handled during and after disasters that disrupt electrical power. So I always like to say it's 6 o'clock Friday night, you've gone home, the clinic's closed, and the power goes out. And it comes on sometime Sunday afternoon. You need to know Monday morning, because the temp's going to be right by Monday morning. Are those drugs safe? And you need to be able to answer that question. What is your process? Do you have a system that alerts you? That's the best, of course. And if you don't, and you're just monitoring temperatures on a log, then somebody needs to be calling you that's on that grid. Maybe it's the hospital, maybe it's the firehouse, maybe it's the police station, or someone to say, when the power goes out at this one, it's going to go out in your clinic, and we need to make a call to you to move those medications so we don't lose valuable medications. Not only lose them, but we have to be sure that they're effective on Monday morning. So RHC procedure may be to evacuate staff and patients when safe to do so, or secure and close the clinic. So there's a lot of different ways to manage this situation, and certainly with COVID-19. Some resources for us. CDC.GOV and CMS.GOV are two very valuable resources, all kinds of good information there. CMS.GOV is a lot more difficult to work with than CDC.GOV, I've found. It's just huge, huge website. And this is the emergency preparedness section of it, and of course they give you ideas if you don't have any, and I know you have them, so I don't mean to insult you. The emergency preparedness rule, of course, survey and CERT here with all kinds of click-ons to, including the tabletop requirements, okay, you can find that there. Frequently asked questions. When you look at the CMS frequently asked questions, you must be sure you're talking about your facility type, because they're all together, and it's huge documentation, and there's hospitals and nursing homes, and of course you don't have to live by those rules. You're a clinic. So it's very, very important to make sure the question is relative to you. We have developed an EP checklist. I'm going to be updating this, and when I do, I will be sending it to Ron Deanne just to make sure an easy way to put the regulation together so that you hit it all in your plan. FEMA.gov also has CERT, community exercise response teams all over the country. In every state has CERT teams, and they offer drills and exercises. If you have trouble getting a drill, you can get involved in one of those. And if you send yourself as a manager of a clinic or one of your staff members, just be very certain that they come back to the clinic and you have a discussion and a training on what you learn and what your role is in that community exercise. And there's a log describing that. Again, we'll talk more about that next time. This is the website for citizenscore.fema.gov and the list CERT.do, and that's where you would drill down to UC Oregon. So this program educates volunteers about disaster preparedness for the hazards that they impact their area and trains them. It's really a very, very good website. Again, right now I don't even know what's going on with them, but I haven't been on there in a while, but they very well may have some good exercises coming up after this. CalHospitalPrepare.org has an incredibly good active shooter exercise that you can copy. You know, there's no reason to reinvent the wheel here. There's plenty of information out there for all of us to learn by, and we can just use it. That's what it's there for. ASPRTRACIE is a government contractor under HHS who only deals with emergency preparedness. So that's all that they deal with, and so it's also a good resource for you. This is another good one. This is Columbia University Emergency Preparedness Toolkit. So like I say, you just get it, you put it on your letterhead, and you make it your own. And of course, additional resources, we have the National Rural Health Association. NOSOR does an outstanding job. The National Association of Rural Health Clinics, and HRSA and RHI Hub. If you don't know these groups, these are all have things for clinics, for sure. NARC, of course, is the clinic go-to. They only have things for clinics, where NRHA covers the hospital as well. Okay, that was pretty quick. What kind of questions do you have? Rhonda Ann?
There's one in the chat box. It's from Linda Compton, and it says, can you clarify shelter-in-place requirements? I was under the impression that we need to keep food and water supply for each clinic staff for a 72-hour period.
If that is true, that would be an Oregon regulation. That is not a federal regulation. That is not. That is a hospital regulation for shelter in place. We don't have patients living or staying in our clinics. Now, if Oregon has done that, I will look that up and see, and I'll know next time. Shelter in place Oregon. I will look that up, but it is not a federal regulation.
And that's all that's in the chat box, Kate.
Okay. Can anybody offer me some ideas on what you'd like to hear next time? Other than the training and testing, which we're going to cover. Anyone? No? Okay, Rondi, go ahead.
There's another question in the chat box. It says, Kate, can you send PPT to each of us?
Tell me what the initials stand for. I'm not getting that.
PowerPoint.
Oh, the PowerPoint. Yes. Okay. Yes. Well, I can. I'll send it to Rhonda Ann, and she's going to post it. But I guess you could send it out, huh? It's PDF. I sent it. It went through email this morning. Okay. Didn't you send it out?
Yes, I've sent it out once, and I'll post it, and I'll make sure that I send it out to Lucinda.
Okay. And listen, folks, the questions can come later. There's my email address, my phone number. Please don't hesitate to call. If you'd rather just chat with me, that's fine. It's been busy on the phone and the emails, but that doesn't mean I won't get back to you. And if you call me and I'm on the phone, I will call you back, I promise. You're in Oregon, I'm in Pennsylvania, so that gives us the evening part to respond to your phone calls as well. Please, be delighted to chat with you. And especially as we get closer to your peak, if there's any issues with COVID-19, or if you want that door sign, I can send that door sign out to you to post on your door. It's really important not to try to keep these potential patients out of the clinic at this time, so we don't contaminate the whole clinic. Okay. We'll give you a little bit of time back. We've got 15 minutes back on your day.
Okay. Well, thank you everyone again for attending the webinar today. There will be the second half of the emergency preparedness webinar on Wednesday, April 22nd at noon, presented by Kate. I will also post the recording and slides on the Oregon Office of Rural Health website under webinars. And if you have any questions, make sure you send them out to us. And thank you for attending again, and have a good day. And thank you, Kate, very much.
Thank you very much. Take care. Be safe out there, folks.